Good to be here with everyone. Nice to see you. So I'm Coach Richards. I'm in the division of EMS. So I am EMS Medical Director along with Jordan Gray for Westchester, along with Stephen Ward for Deerfield Township, Hamilton Township, and then for Mobile Stroke Unit. So I am more than happy to join you today. The way I'm kind of conceptualizing this, and if you've heard me give CE in other settings on acute stroke, I kind of talk about a lot at once. And so what I kind of propose to Dr. Lubbers is to kind of break this up into actually a couple different sessions, at least two. And this first one allows us to kind of take a little bit more time and just talk about the key concepts behind acute stroke. So you'll actually notice that I'm not going to actually talk a ton about the ways of evaluating stroke patients in the field, where these patients should be thought of about destination. I just want to really kind of talk about just the key and the core concepts behind it. A lot of this is going to be reviewed, to be perfectly honest, and that's a good thing. Some of it will be kind of my take on it, but a lot of it actually is rooted in sometimes what I find is an observation, which is to say we have a lot of kind of focus on identification of stroke patients, a lot of focus on like, well, we have to be like really timely and go straight to CTs, and then we kind of do all this like hurry up, and then at the end of the day, we're kind of like, oh, that patient didn't end up getting treated or these sort of things. And sometimes it can actually be a little bit of like, hey, we did all this hustling, like what kind of was going on with that? And so I think it's important for us to kind of understand some of kind of the decision making that happens kind of in that acute phase, rooted in some of the pathophysiological concepts. And so that's kind of the scope of what I want to talk about today. And then this actually serves a lot as the underpinning for what we do in the field, which is the stroke screening, the severity screening, the thinking about where these patients should be brought to. So we'll talk about that in a later session. So first and foremost, stroke is obviously something that we'd like to avoid, but here's the scope of the impact that the stroke has. And ultimately, almost 1 million people a year end up having a stroke, and while there is a mortality associated with it, the reality is that the morbidity, especially for severe stroke, and you see this when you make nursing home runs and long-term care facility runs, when patients with stroke and they end up being confined to bed and are severely dependent, those patients end up with complications otherwise, and that's, kind of less than ideal when, at least for some of those patients, they could have potentially come back to a little bit better functioning. The other part of this, too, is that there's a disproportionate effect generally on kind of less resourced populations, women, minority, and the elderly as well. And so it's a condition that is good for us to kind of know about pathophysiologically, which again kind of informs our on-scene care. And the flip side of this too, just over the last year and a half, there is probably at the end of the day a bit of an association with COVID-19, just the pro-inflammatory state, and then there were kind of reports of large vessel stroke, so kind of thrombotic lesions increased in incidence, even in populations that we don't typically think about, so like the young. All right, so here's kind of the basic concepts and the review part of the talk, which is just a stroke. But again, this is all kind of leads into a foundational aspect of kind of how we think about what we do moving forward. So stroke, at the end of the day, is any disruption in the blood flow to the brain itself. Now that leads to sudden neurological symptoms. Typically, we think about that as weakness of some sort, whether that's arm, leg, and face. Those are the classic ones, right? We think about this as potentially slurred speech or aphasia. That's another pretty typical symptom. But the reality is that those, while common, are certainly not the only neurological manifestations when blood flow is blocked to certain parts of the brain. Depending on kind of where the anatomy is, altered mental status can be an initial presentation, especially if it's the part of the brain that does your balance center. Dizziness and vomiting can be overlapped. Depending on what type of stroke, severe headache we'll talk a little bit about hemorrhagic stroke here in a little bit. The other interesting part too is, so this photo right behind me is a screenshot of a woman who had been experiencing transient ischemic attack. So that is on the same spectrum as stroke. TIA is essentially just a brief and resolved episode of blockage to the brain without residual deficit, who was trying to explain her symptoms to her care providers, and experienced symptoms again, and was like, I need to videotape myself. So she's like driving to the hospital, videotaping herself having a TIA or a stroke. Hard to know exactly at that time. But you can kind of see that she's exhibiting some of the more classic and traditional things that we think about when it comes to stroke, the facial drooping, and she has some slurred speech as well. Often when we think about stroke, we conceptualize it in the context of ischemic stroke, which is just a sudden blockage of the blood vessel. So everything past that blockage is just not getting blood flow, at least from its primary source. So over time, that relative ischemia, the underperfusion, will lead to infarction, just like you do for myocardial infarction, heart attack, just like you do for, when your tourniquet is up for 8 hours or something like that. Anytime you just don't get blood flow to an area, then you kind of progress from ischemia into infarction. And eventually that's what happens with acute stroke. Now, while I kind of conceptualize it as kind of this picture portrays, which is kind of an area of the brain is fed by like a single vessel, there's actually a little bit more subtlety. So there are what we call collateral vessels, so blood vessels that come from other parts of the brain into kind of part of the cortex that can actually help give oxygen, nutrients, at least for a period of time, to that area at risk. And so it depends actually a little bit on how well those collaterals are feeding an infarcted area in terms of the patient's overall stroke burden. And that's actually, we'll talk about this in a second, as why that blockage gets there. But that's actually one of the bigger reasons why we think about traditional stroke risk factors, smoking, hypertension, hypercholesterolemia, because those risk factors are ones that attack small vessels. They put you at increased risk for kidney disease and renal disease and heart disease. Well, same thing with the brain, except it's more actually to affect those collateral blood vessels, because if you do end up getting a blood clot in one of the blood vessels, you really have a decreased chance of supplying those perfusion, those collateral vessels to give the perfusion, while hopefully we're hatching a plan to get that brain reperfused. Now, the other part of this, too, is that not only are the neurons at risk, but also are the rest of the blood vessels. So you can see kind of in that dusky gray color, the blood vessels are also becoming ischemic. And that has some implications for some of the therapies and the time frame that we deliver them in. Sometimes I kind of think about the way this happens is kind of like this unfortunate tree that had a fungus or maybe just a giant cicada at its base or something like that, and it kind of killed off the entire branch there. The rest of the brain is actually getting good blood supply. Like it's doing okay. It's just that one area that's fed primarily by that blood vessel that has the obstruction that is really at risk. Now, I've mentioned this already, but typically that blood clot, the blockage is a blood clot. This is, especially the larger vessel occlusions, a thrombus of some sort kind of usually goes up into one of the blood vessels around the brain, causes a blockage in blood flow, and you're on your way. It kind of obviously depends on how big it is. If it's a really small one and it finds a really small distal vessel, then you'll have symptoms related to that. Typically, when you have blood clots like this, it does come from the heart. Usually, people develop blood clots in the heart when they have atrial fibrillation. You have that uncoordinated motion in the atria, and that is why atrial fibrillation patients are on anticoagulation to help reduce the chance that stagnant blood in the fibrillating atria will develop a blood clot that can go elsewhere. There are other mechanisms, though. So there's a concept called ICAD. So this is intracerebral atherosclerotic disease, where it's not exactly like this picture describes, but I think it's a good enough analogy. The picture here is really what happens more commonly in STEMI, where you kind of have a plaque, you have some narrowing, and then one day you'll just have a rupture. There is that concept in acute stroke. Typically, it's more akin to the top picture that we see, where you just kind of have narrowed blood vessels, and then if you're just kind of scooting by the blood vessels, the blood cells as best they can past these blockages, and then let's say you are hypotensive for some reason, maybe you've syncopized, maybe you're septic, maybe you're dehydrated, then the pressure head on these already chronically suboccluded lesions can be compromised, and then you can have symptoms beyond that. So sometimes actually treatment for these situations is just optimized blood pressure management and to increase that pressure head to kind of move through. There are other more rare conditions. You can actually get vasospastic events that can lead to ischemia. There are certain congenital conditions. Patients with sickle cell disease, with their sickling of the blood cells, can cause occlusive events. And so while we typically think about it in terms of atrial fibrillation and kind of arterial disease, there are other reasons even to have ischemic stroke. Now, when it comes to ischemic stroke, a lot of the symptomatology depends on the blood flow to the brain. While there are collaterals, the reality is that the area at risk does have that primary blood supply, and that really does lead to the overall symptomatology. So here's kind of a real general schematic of how blood flows into the brain. It kind of starts coming in through, actually branches off the carotid artery. They kind of form a network kind of right in front of the brainstem, and then they get some blood flow from the back of the neck, the vertebral arteries that kind of come in and join there, and then branches flow from there. So typically the ones kind of coming off the vertebral kind of form branches that go to the cerebellum. The ones from the internal carotid kind of branch off, and then one of the biggest branches is actually depicted right there, which is the middle cerebral artery, which comes out and does a lot of kind of the parts of the brain that we typically think about in the context of acute stroke. The function on the brain is actually pretty well mapped out. This is something called the homunculus, and you can actually map functional areas of the brain to kind of where it lands. And so if you have a middle cerebral artery, it really does do this part of the brain, the hemisphere there, and you can have arm and leg and face weakness, and depending on kind of how far out the blood vessel is actually occluded, can tell you kind of the severity of some of those symptoms. Now, this is also important when we think about not only kind of focal weakness, but also speech changes. So it is not uncommon for patients to have aphasia if their dominant side is also weak. So for a lot of people, that ends up being that they're right-handed. Typically, if you have weakness on the right side, then you'll also have speech changes. Whereas for that same person who's right-handed and they have deficits on the left side, their speech actually may be preserved. Most people, their handedness is on the same side of the brain as their speech center. So I'm right-handed. If I have a right-sided hemiparesis, I'm probably going to be having speech changes if I have, and that'd be a reflection of a left occlusion. Because remember, the left side of the brain controls the right side of the body, and vice versa. So here's again kind of a representation. This is where the speech center is. It's in the MCA distribution. The balance center again kind of comes up kind of from the posterior aspects. And then a lot happens in that middle area, the basal ganglia, thalamus, these sort of things that kind of integrate all the fibers and tracts coming from the cerebral cortex down to the rest of the body. The other part of this too is where all those blood vessels kind of come together at the base. You do have. Let me see if I can do this. All right. Is when all the internal carotid arteries, vertebral arteries come together. They have a circle of Willis, but in very close proximity to that is something called the basilar artery. The basilar artery does have some branches that go and feed the parts of the brainstem that actually keep your consciousness awake. And so if you have a blood clot there, you could actually have not focal deficits, but rather just obtundation or altered mental status, or they may look intoxicated. Actually, you can have meiosis, so pinpoint pupils for patients who have basilar artery strokes without focal deficits. So that's why, while we typically think about what I just called classic symptoms, those are really middle cerebral artery symptoms. Those are symptoms of the part of the brain that you can see right here. But any of these blood vessels can get occluded and result in symptoms that are related to the brain function behind it. And so some of the challenge here is that not only can it be sometimes challenging, especially when it's not those middle cerebral artery symptoms, but they can look like other things, especially in patients who have a high risk for intoxication. Maybe they're chronic substance abusers. Maybe they are actually intoxicated at the time, either with alcohol or otherwise. There are actually conditions for intravenous drug users. They can develop vegetations, infection of their heart valves, and those can get flicked off and cause occlusions in the brain as well. Hypoglycemia is the great mimicker. That's why we always check glucose prior. Vertigo is probably one of the more vexing syndromes, actually, to determine whether it's a central cause, so just your balance center in your ear, versus a posterior circulation cause, so a problem going on in the cerebellum. And then part of this, too, is that it may actually be hard for the patient to actually describe what's going on. So not only may I have an aphasia or really limited speech, so even if I knew what I wanted to say, I may not be able to get that out because of how the stroke is affecting my brain. But the other part of this, too, and especially as it turns out, for actually more of the severe stroke syndromes, is that they may actually have neglect. So if I'm having a really severe stroke and I can't move the left side of my body, if I'm experiencing neglect, it is possible that I may not even recognize or realize that I'm having symptoms on that side of the body. If you ask me to move my arms around, I will say, all right, I'm moving my left and my right arm here all at the same time. And you'll look at them and be like, no, you're really not really moving that left side. But that's part of it, is that they almost won't recognize that as part of their body. It's really it's a fascinating. If you really do see it happen, you should be attuned to it first off, but then you'll find it interesting. Part of that too actually plays into that, and whether it's neglect or whether it's a visual field deficit, is that if you come to the patient's bedside or cot side on the side where they're experiencing a lot of deficits, they may not actually either see you, like have a visual input of you, or they may neglect you. And so if you start asking them questions on the side where they're actually having a lot of their motor symptoms, and they don't respond, it could 100% be either they can't see you because of the visual field deficit, or they may actually be experiencing neglect. So even just a simple intervention like moving to the other side of the cot, if you're able to, actually can go a long way. And then we talked about kind of the range of alertness as well. All right, so that's ischemic stroke. That's the most common that we see. The other stroke syndrome that is just as important, although at the end of the day, somewhat different disease process, which is hemorrhagic stroke. So we conceptualize this still as stroke. Hemorrhagic is just bleeding in or around the brain. And so this is when basically one of those blood vessels, and ends up usually being a smaller vessel, has a rupture. And it starts bleeding into the brain parenchyma itself. So that's not only a problem because then you don't have adequate blood delivery to the brain cells beyond it, but then also you're just getting blood into a space where it shouldn't be. And so then you start having mass effect as well. The risk factors for this are the ones that we typically think about, those small vessel disease risk factors, like, again, smoking, diabetes, hypertension, hypercholesterolemia. And typically it actually does happen in kind of this deeper part of the brain. That's a pretty common place to see it. If you end up having really larger hemispheric infarctions like this is an autopsy sample, obviously, you can have obviously pretty severe syndromes. Now, the symptomatology can actually be somewhat overlapped with severe stroke. So this patient actually, initially, when the hemorrhagic stroke was a little bit smaller, very well could have had deficits similar to a large vessel occlusion, an ischemic stroke in that area, because the blood flow to that kind of hemisphere was not working. So my guess is that probably this patient was having right-sided deficits at some point along the way. I have to imagine that the amount of bleeding increased the pressure, and so they probably quickly moved to obtundation. But you can imagine that a syndrome like this actually could have produced like a right-sided weakness. Here's what, if you happen to hang out in the CT scanner after you bring them in, this is what acute blood on a CAT scan looks like. This is pretty similar to the pictures that we were looking at earlier, which is kind of those deeper areas experiencing bleeding. And actually this one goes into the ventricles as well, which is just an extension of the parenchymal bleeding, so the brain tissue itself, the blood that was happening there, it just kind of like seeps into the ventricles and then kind of clogs that whole area. Typically, these patients, while we talked about some of the symptoms being overlapped with ischemic stroke, oftentimes they're going to have elevated blood pressure. So if you kind of see the emergency doc, and you all pick up on this all the time too, but if they're like, 220 over 140, and they're like just not acting right, or they're weak on one side, or they're kind of confused, obtunded, and everyone's like, oh, this is going to be a bleed. Oftentimes we're thinking, this is kind of the direction that we're going. We're obviously not 100% right when that happens, but that tends to be a pretty common presentation for these, especially larger interparenchymal bleeding. When the blood ends up kind of hitting the outside, the arachnoid mater, that's very well innervated, and that can be a painful experience. It can also cause a ton of nausea along with it. If the bleeding is actually deeper in, there's not really pain fibers there, and so it may not be a painful experience. They may not have headache unless the intracranial pressure is really starting to increase and increase and increase, and that is when you start having kind of nausea as well. The exam, again, may have focal deficits. It may just be a globally decreased mental status. It may just be severe headache, to be perfectly honest. At some point, these patients will have an increased risk for seizure, and so, especially if it's been going on for a while, at least having some preparation on board for that. I wouldn't advocate giving prophylactic benzodiazepines or anything, but just to recognize that the patients may end up seizing on you. And if they do, then you treat them. But and eventually, if you really have so much pressure built up, you can press on the respiratory centers and then cause a respiratory compromise. Subarachnoid is another type of stroke. So what we talked about there was interparenchymal, or what's usually called ICH, so intracerebral hemorrhage. Well, that's a little bit of a broader term that could include subarachnoid hemorrhage. So that's typically where someone has an aneurysm in their brain, and then the aneurysm just has a weak wall that at some point is prone to rupture. Now, what typically happens is that you get a little bit of a what's called a sentinel bleed, so a little bit of a warning bleed, and so some blood is released, and that blood hits that arachnoid mater surrounding the brain. Again, lots of nerve endings there, and causes severe headache. Now, what we like, if someone has this condition and they have a sentinel bleed, we like to recognize that early, because what can happen is that the initial rupture of the aneurysm can actually be contained. The patient can do okay for a short period of time, but at some point there's going to be a rupture of that aneurysm that just the body's not going to be able to heal up, and those end up being catastrophic events. So the goal is to find patients with these sentinel bleeds, intervene, get rid of the aneurysm, so they can live without that risk. Well, you can see here vasospasm. So actually, even patients with subarachnoid hemorrhage, with all that blood in and around their brain, can actually cause some vasospastic of the arteries and actually lead secondarily to ischemic stroke, which is kind of a bummer. Usually that happens in the ICU days down the road, but at least so that you're aware of it. Sometimes subarachnoid bleeding can affect kind of focal areas, but usually it ends up being just kind of like a bathing of the entire brain, and so that's where kind of like the severe headache, or if it's a worse event, then the abdomination. Typically, these patients have all signs of meningismus, and so those would be what we see in subarachnoid bleeding, something that we see in meningitis, which is just irritation of the meninges, so neck stiffness, severe pain, nausea. Now, this is different than other types of bleeding that happen inside the skull that we think about usually in the context of trauma, like subdurals or epidurals. These are typically not considered on the same stroke spectrum. I mean, even if you're talking to the specialists at the hospital, they end up being different specialists, even different neurosurgeons. And so just to kind of frame that in the context of what we end up talking about when we talk about acute stroke. Typically, ischemic strokes are far more common, although I'll tell you that it is more common for hemorrhagic stroke patients to use 911, and so the ratio of what we see in the field is actually a little bit more skewed toward hemorrhagic. It's not anything nearly 50-50, but it's probably closer to like 20-80, maybe even 30-70, something in that ballpark. Now, when it comes to acute stroke therapies, the goal is, at least when it comes to ischemic stroke, is to restore blood flow to areas that are at risk. So there is an area right after that blood clot that essentially the collateral vessels are just not going to be able to help sustain, and that is a lost area. That's something called the core, and that's infarcted tissue. But our goal when it comes to treating patients is to help save that penumbra around it by restoring the blood flow. It's at risk, not dead, ischemic. And that's kind of where that adage of time is brain comes into play. And this is where you've clearly heard this already, but believe it or not, actually, for every 15-minute interval in treating patients, you can actually have like better outcomes. And it may not necessarily be that they have zero symptoms at the end, but it might be that they are able to live independently, that they're able to go home rather than a longer-term facility, although there actually is a mortality benefit as well. The most common treatment that you'll see is something called alteplase or IVTPA. There's others on the market that are not FDA indicated for acute stroke, but you might kind of hear about in the future as studies kind of come out. Tenecteplase is another medication that sometimes is used in this setting as well. But the main goal of all of it is just to basically chew through any clots that might be there. And so whether that's a really small one in one of those branch vessels or whether it's even one of the larger ones, the goal is to kind of break up that tissue. Now, across the board, patients do have an increased chance of having better functional outcomes after getting thrombolysis, but not all. So you can see that kind of on the balance, and when kind of the stroke team physicians talk to the patients, they'll quote a number to say, you know what, there's a chance that you can get better, and you can kind of see the top line of the dark green kind of gives a visual representation of who might be expected to get better. There's a large number there in the middle who may get the therapy, who would end up getting the therapy and may not actually end up having any improvement, and we have to recognize that. And there's a smaller number, as high as even 5% or 6%, that may actually be harmed in some way. And the harm generally comes from the way that the TPA or other thrombolytics work, which is it chews up clot. And so if there's any clot anywhere, that clot goes away. And remember what I said too, is that it's not only the neurons that are dying, but it's also the blood cells that are the blood vessel cells that are dying too. And so as time goes on and the blood vessels are dying, and then you blast a bunch of blood through there, you do increase the risk of bleeding. And so you kind of have the two together, and it does potentially lead to some bleeding complications. We'll talk about that in a second. The other therapeutic option that, of course, you know about is something called endovascular therapy. This really blew up in 2015 when there was a series of studies that showed really pretty dramatic benefit for patients who went and got a minimally invasive procedure to actually take out that blood clot. It's called endovascular therapy. It happens in a couple different ways, but ultimately you put a catheter through the groin or the wrist. You can actually suck out the blood clot, or you can deploy this, basically it looked like a chicken wire, through the clot, expand it out, and then kind of hopefully dry the clot out and reperfuse. that procedure is only available for patients with large vessel occlusions, basically kind of the first branch, that middle cerebral artery, sometimes the anterior cerebral, which does kind of like the front part here, which does a lot of kind of personality things. And then there is some data on basilar artery conditions as well, although the guidelines are less robust for that. This is what it looks like on the CAT scan. So kind of the area there on the, so it's, as you're looking at the screen, it's on the left side. That's the right side of the brain. But you can kind of see all that kind of contrast material, kind of all the spaghetti noodles of blood vessels. That looks pretty good on that side. On the opposite side, you can see that there's just like an abrupt cut off of kind of the blood flow, where on the other side it kind of goes, and all that area is kind of a little bit darker beyond it. That's just a brain that's just not getting great blood flow. Now we can actually use CAT scans to actually see how the brain is affected. And you can actually conceptualize a CAT scan series of images as penumbra. So the top part, that red, is actually related to the core, the infarcted area, and the bottom part on the CAT scan is the green. That's the penumbra. And so this, unfortunately, is not a very favorable mismatch, but sometimes you can see like whole areas of the brain that are just all penumbra, all green, and a very small area of red. And those are actually patients that they will go in and do endovascular even up to 24 hours. So even at 24 hours, if I have a really small core, that red area, compared to the green area, the penumbra, those patients actually, across the board, had the potential for benefit even up to 24 hours. So benefit treatment is time dependent. That's why we kind of push for those scenes and rapid evaluations. But even when we do that, the reality is that not everyone actually can be eligible for TPA. There is that risk of bleeding that I talked about, and a lot of kind of the eligibility that we think about goes into thinking about who is at an increased risk of having complication, generally bleeding complication afterward. And it ends up being, folks, the biggest one is time. And so Alteplace's FDA indicated up to 3 hours. Guidelines recommend up to 4.5 hours with symptoms, as long as there's no bleeding. But reasons to exclude patients beyond, even within those 4.5 hours, is the whole list there in that gray box. And you don't have to see it, but just recognize that there's a lot. There's a lot that actually goes into the consideration about risk, weighing the risks and the benefits. The most common ones are anticoagulation use, recent bleeding, recent surgery, trauma, these sort of things. So this is one reason, probably the most important reason, that even if you're kind of hustling, you're going about your way of getting the patient there for evaluation and they don't end up getting potentially thrombolysis for what seems to be a stroke syndrome, the stroke team is going through this whole list and others about thinking about who the Alteplace has a benefit rather than a harm in giving. Now, the flip side of this, too, is that while we think about thrombolysis in 4.5 hours, patients can be eligible for treatment up to 24 hours, like I said, in the right circumstances. And so typically up to 24 hours is for patients who are eligible for thrombolysis. But the reality is that even if the patient wakes up, for example, there are certain MRI protocols that the hospital can do to know if they actually might even be eligible for thrombolysis. So if the bottom line there is that if you do end up assessing a patient with acute stroke, even though that it seems like they might have a contraindication based on time, still having them go to a stroke center, it's important because they might be eligible only for a thrombectomy. They might actually be eligible for thrombolysis as well. The last thing that I'll just mention here is the treatment of hemorrhagic stroke, just to kind of round it out because we want to talk about both. And typically, obviously, thrombolysis is not going to be on the table for these patients, but basic ABC management. The most important part here is to reduce that pressure head so you're just not spurting blood through that ruptured blood vessel. If they're on anticoagulation, to reverse that. Ultimately, to reduce the amount of swelling that's happening and to help kind of preserve the brain. You do that in a couple different ways. 3% saline, mannitol, these sort of things. Ultimately, they may actually end up going for surgery and just basically take the skull off to act as a site for that swelling brain to go into. And like I said, oftentimes they end up on seizure prophylaxis. So that was just kind of setting the stage for future discussions that we may have in the same setting. We just talked about the types of stroke. what we're kind of thinking about diagnostically, therapeutically at the receiving hospital, and ultimately that will inform our discussions about what that means for us on the scene. So I appreciate everyone logging in today and in real time here, and then to watch it afterward. I look forward to questions if anyone has them.